So how about the next one, no? History of present illness. So this is the most important part of the psychiatric interview, and yet there is disagreement on exactly what it should entail. Some think of it as a history of present crisis. Others begin by eliciting the entire history of the patient's primary syndrome. So the thing with the HPI is that sometimes, no, sometimes when we meet patients, 1 hour na nagstorya, history of present illness pa. Because sometimes it's so rich that there's so many things that you want to ask them. So the history of present crisis approach. No? Often, psychiatric crises occur over a 1 to 4 week period. So focus your initial questions on this period. So, example, nagsugod ni tanan. Ngayon sila, ma'am, nagsugod man ni atong duha kasi mana miyagi. No? So the questioning would be, what has been happening over the past week or two that has brought you into the clinic? Tell me about some of the stressors you've dealt with over the past couple of weeks. So, alternatively, you can begin your questioning by ascertaining when the patient first remembers sign of having these kinds of problems. If you notice, no, tentenismo. This is given that a patient, the family will be the source of information, but given na maka-answer sila, they should be the primary source of information. Secondary na lang yun ang family members. Write-ups are organized in this format. They often begin, the patient was without any psychiatric problems until age 18 when she became depressed. So, nga nga mag-history taking. Elicit a chronological narrative emphasizing precipitants. Many patients automatically jump into a chronologic narrative of their problems when prompted by one of the preceding questions. If this happens, it is a time to fall silent for a while and listen. Sometimes, you don't need to direct the conversation. Kaya sila na dahil, magsaysay namin. It's like, sugod mo ni Doc at itong high school ko, fourth year high school ko, nga ni nahitabo, blah, 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 blah. So sometimes we just butt in to ask further questions nga wala kay nila di-explore maayo or wala kay lagi storya ang mga detalye. So remember, this is your scouting period during which you are observing, listening, and hypothesizing. So what are the common precipitants of psychiatric syndromes, no? So this is what you're gonna ask, no? Was there combination? Can you remember any stressor that could have led to this symptoms you're telling me right now? No, these feelings you're telling me right now. Wala man. So actually, you could actually ask this, no? Any arguments with friends and family? Any rejection or abandonment? Any death or major illness of a loved one? Anniversary of a negative event, such as death or divorce? So that you will help them remember a possibility na ay precipitant. Because for some patients, they don't know it, but they are so keen into denial that they don't know. Modeling cause. Major medical illness or age-related deterioration in functioning, stressful events at work or school, mental health clinician going on vacation, and substance abuse. So we also launch into diagnostic questions right away. No? One of the secrets of efficient and rapid diagnostic interviewing is a gentle tenacity. When a patient mentions a depressed mood, immediately assess for the presence of the diagnostic criteria for depression. So sometimes, you have to know about the symptomatology. Example, na-mention sa pasyente, kabalo ka, Doc, ato bitang 2 months ago na depressed man ko. Pero after ato, Doc, didala mo ko sa akong mama o papa sa bakasyon namo ng atumig Bohol. So the conversation would go na to the vacation. But if you know the symptomatology and you have active listening skills, no? What you will do is that, can I ask you more about the depression that you've mentioned? No? So imo na dayon nang pakutanon ang symptoms of depression. How was your sleep at the time? No? How was your appetite? How was your mood at the time? No? Your functionality. Were there any thoughts of suicide? Did you find yourself very hopeless, helpless, and in severe guilt? No? So these are questions. These are DSM-5 criteria of depression. usually they will just mention the word. Pag ingon ka depression, you could actually assess that para makabalo ka ba katubang depression ilang giingon muna ba ning major depressive na ba ito nga sugod. Because we just don't take it as it is. Some people would call psychosis depression. Ingon sila nga depression magud na siya ato doc. So if you sometimes will you believe on those words depression, pag mga tana din ka naghubo sa dala, nasayaw-sayaw, that's not depression, that's psychosis. So depression is a commonly misused word. So we better clarify what that is. I think the worst problem over the past couple of weeks is that I've felt so down about myself. Has that down feeling been affecting your sleep? Oh, so muna yung transition niya. Sleep is a symptom of depression. So muna yung transition mo. Tana na siya symptomatology of depression. I haven't slept more than 2 or 3 hours a night, and the next day I can barely drag myself to work. I should probably quit anyway. It's a boring job. Have you had problems focusing on your work because of your depression now? No? The doctor is asking about the cognitive skills in terms of concentration and memory. No? So that's what it means. No? Obtain the syndromal history. No? Generally speaking, the HPI will take between 5 and 10 minutes, at the end of which you should have a few provisional diagnoses in mind. 5 to 10 minutes, ano na lang ka-idea kung unsa ni possible nga problema. No? Is this a psychotic disorder? Is this a mood disorder? Is this a trauma-related disorder? No? So, magka-idea lang ka. No? Your next job is to obtain the history of these syndromes. So, imo na din kalkalon. So, magdidining historyhan ni kung depression ni ato aning specify. Specifically, you want to learn age of the patient at the onset of this illness, the pre-morbid functioning. Unsa di ka sa una, no? Sometimes they did not mention it sa una when you ask about the pre-morbid. Now that you have a comparison, ngayon kanina siya karon, mas easier madelineate kung unsa di sa una, no? And history of subsequent episodes up to present. So, general questions: what sort of treatment have you had for your depression? What was the most helpful? So, naagibutang ang champ, no? So, current caregivers, who's the one taking care of you right now? Have you been admitted to any hospital? What was the year niya nga admission? Unsa rason nga na-admit ka? Ano na-admit ka ato? Medication history, the side effects. So you would also know if you wanted to start this medication or dili na. Yan ang gigamit sa una, wala ni epekto. Yan gigamit sa una, grabbing side effects. So we don't want that. We don't want to do that again. Or psychotherapy history. Have you had any psychotherapy sessions in the past? No? So the mnemonic jump, so you don't miss any category. So screening for major medical conditions. 2 major reasons for asking about the medical history is: number 1, to screen for medical illness. Whether the condition affects their psychiatric status or not, you will do them a large service by screening for medical conditions for which they may not be receiving treatment. So it's important, no? Because we want holistic care. Basig og ka ng high blood, sila pero ipabayaan na nila ilang high blood. No? So we also wanted to educate them about it as much as they wanted to take care of their mental illness, so as well with other medical illnesses. Another thing is to uncover general medical causes of psychiatric illness. No? For a lot of times, no, I've encountered several referrals. Ilang tanaw is psychiatric illness, but really the cause is medical. No? Grabe lang medical cause. Medical illness can cause psychiatric illnesses, no? Sample HIV, SLE, stroke, all those. A lot of mga delirium, no? So mga cause ng mga delirium: septic enceph, hepatic enceph, no? Hypoxic enceph. All these things are causing behavioral changes. So it's very good that we psychiatrists will be able to delineate if the behavioral change is secondary to a medical cause, or is it secondary to a primary psychiatric illness? Because when it's a psychiatric illness, then we will do the management. If it's the medical cause, then the medical people will do the management, and we could be supportive in terms of behavioral control. So these are the questions that we need to ask: no? Medications, illness history, primary care doctor, allergies, and surgical history. So the medical review of systems, the purpose of this is to review the systems, that is to note medical problems that the patients may have forgotten to describe in response to the MIDAS questions. The MIDAS may miss seemingly minor symptoms that may be the first clues to a big problem, such as occasional cough that signals lung cancer. So, brief versus full review of system. So, brief. Kasi sa na ito ginabuhat ang brief lang, no? For young, middle, or upper class. Rationally, because statistically, fewer medical problems and good follow-up with doctors. So, mas dili na kayo extensive. But for elderly and chronically mentally ill, they need to have more detailed because they have more medical problems and poor follow-up with doctors. So for psychiatric patients, no, someday if you become internists, if you can become surgeons, if you become OB-GYN or pediatricians, and you know that this patient has a background of psychiatric illness, no, I urge you, please make your review of system extensive so that you will be able to get and assess the patient's medical conditions. So example, I'm going to ask whether you're having problems with various parts of your body, from head to your toes. Any problems with headaches or seizures, vision or hearing problems, smelling, taste or throat problems, thyroid problems, problems with your lungs like pneumonia or coughing, heart problems, stomach problems like ulcers or constipation, problems with urination, joint problems, problems of walking. No? So this is the ROS. I think, I'm not sure if you've already been taught about ROS. So the ROS that you will be having for psychiatric history will be the same ROS that you will also have in assessing the medical history. So extended review of systems. Overall, do you feel healthy? Joint problems or skin problems? No? So I will not go through all of this because you may read through them in your own personal time. But this is just basically the same with all the rest of the all the rest of the medical history.